Good evening. I would like first to thank Mr. Chairman and the audience, and of course Dr. Cooper and Dr. Lloyd, to give me the opportunity to share with you our experience about the what to do with the aortic root in acute type A, and I have no disclosure except these dramatic things. So next year, guys. And I would like to address a very friendly thanks to Jeffrey Tsang and Steve Livesey, because from now 8 years we share a very nice academic program between Rennes and Southampton, and we have now 8 trainees and fellow to work together. So it was difficult to didn't speak about history. This observation, I know that as English people, you know that history, but I think it's very, very interesting. And this first description of enteriter in the root of a heart and of a majestuous heart is a very interesting thing, and the impact of history is very nice. And Dr. Svensson know now why they have in US their independence, and that independence history have been suspended to a tear. Thanks. So my proposal is back to the future, where between a rock and a hard place, it's interesting to debating regarding the management of the tubular ascending aorta in type A dissection. However, the management of the aortic root and the arch remains unclear, while some authors advocate for a conservative approach. There is growing debate on the extensive repairs of the root and the arch, aiming at reducing further aortic complication and re-interventions. In an aside regarding the arch, we have recently reported in the French elective frozen elephant trunk registry about chronic dissection that on 1/3 of our cohort had previous type A dissecting repair. It is indeed no secret that a dissected aortic arch will require over time re-intervention and an important group of patients. So what about the aortic root? Obviously, let's forget that the priority in the setting of type A ascending dissection is to get the patient out live. The extent of the aortic repair comes next, and one has to decide, often at night, often alone, between two strategies and their trade-offs. If sparing the root grants a quicker procedure, technically easier, it also puts the patient at risk leaving a pathological root, and those with risk of root events, including aneurysmal disease, recurrence of dissections, and aortic regurgitation. Alternatively, replacing the root excludes proximal pathological aorta, but may come at the price of heavier procedure, technically more demanding and possibly riskier. Valvular complications at follow-up are moreover not excluded. So, at the root of the problem, if I may say, 3 questions ought to be asked. First, about the fate of the spared aortic root after an acute type A dissection repair. Second, regarding this spare root, whether actually reoperations that carry a high surgical risk. And finally, when the root is replaced, if the replacement technique does impact the outcome. So before answering this question, a first step through the current guidelines. The European guidelines address a part of the question, stressing that aortic valve can often be preserved at root repair or given the emergency of the situation. The valve could also be replaced. However, if dissection involves at least one sinus, which in our practice is very common, the ESC guidelines recommend to replace the root. Several settings are not specifically addressed, mainly dilated, non-dissected roots, Marfan patients, or older patients. The 2010 American guidelines, also with a level of evidence C, precise that a partially dissected root may be repaired, except in the case of extensive dissection that should be treated with root replacement. Moreover, in the setting of dilated aortic root, replacement of the root is also recommended. We can see the current guidelines address partially the issue of the aortic root during type A dissection, and that further and more recent investigation is required. Fate of the preserved aortic roots after transaortic type A aortic dissection. In a multicentric retrospective study published in 2016, Yale, München, Beijing, Innsbruck, and Kazan, including 338 type A repairs, and only 26% of the roots were replaced. Both strategies had equivalent operative mortality and survival rates at 10 years. Upon follow-up, the authors also demonstrate the slow growth of the aortic root after type A repair. For instance, a 40 millimeters root at index surgery only grows by 0.42 millimeters a year. So, to reach 15 or 15.5 millimeters aortic dilation, it will take at least a decade. This is the first important message regarding older patients. This Italian 23 years follow-up paper with 319 type A dissection with exclusive supracoronary repair also demonstrate that less than 10% of preserved roots will require further intervention at 10 years, and less than 20% at 23 years. From the IRED registry, this paper from 2014 reports almost 2,000 type A dissection with 35% of root replacement and 65% of root sparing procedure. In both strategies, operative mortality, 3 years survival, and freedom from root reintervention were similar. Root replacement was not found to be associated with high mortality, while age over 70 years old was associated with an higher operative mortality. Regarding the risk factor that might impact the risk of reoperation of aortic roots, the study from the Fribourg team suggests a higher risk of reoperation, 10% at 4 years, identifying the dissection of all aortic synovitis as a predictive factor of reoperation. In this Japanese paper, from his over 300 type A dissection, 87% of patients were treated with supracoronary graft. On one hand, they report a higher mortality associated with root replacement versus supracoronary repair. And they also identify the dissection of 2 or 3 sinuses as risk factors for late aortic events. In these last 2 studies, neither age or gender were found to be associated with a higher risk of aortic root reintervention. This multicentric Freiburg and Philadelphia study from 2014 is very compelling. A 74 Marfan patient with type A dissection was evaluated. And first striking thing is the median age of 37 years old. In the setting of Marfan patient, they report a 70% root replacement with an excellent in-hospital mortality reported. Among the supracoronary group, 40% of patients will require a root replacement at 8 years. Overall, more than half of the study cohort required aortic reintervention at 8 years, and this is compelling and strongly favors more aggressive strategies in Marfan patients. Importantly, survival at 8 years was similar in the 2 groups, aortic reintervention and no aortic reintervention, emphasizing that in trained teams, reinterventions do not carry a higher risk, and we know that these reinterventions can be extremely complex and challenging. Finally, in this 2018 paper from Stanford carries overall the same message. With near 300 type A dissection, 72% of supracoronary repairs, operative mortality and survival at 10 years are similar, at cost of a higher risk of reoperation in preserved aortic roots, 11.8% of reoperation at 10 years. Does aortic proximal reoperation carry high surgical risk? So now that things are getting clearer about the fate of preserved roots, what are the outcomes in those 10%? This study from the Duke Medical University reports 219 reoperations after prior type A dissection repair, including 47 of proximal reinterventions. The vast majority of procedures were performed electively with a 7% in-hospital mortality. These results emphasize that with a close follow-up, most of the reintervention can be performed electively and those performed by senior aortic surgeon or transferred to aortic center. These authors therefore suggest that the fear of a potential reoperation must not dictate the strategy at indexed procedure. Similarly, Hazim Safi teams from Houston report 63 reoperations after type A dissection, including 27% of root replacement procedure. As we can see, those reinterventions also include arch replacement and stage 1 elephant trunk procedure. Despite the complexity of these reinterventions, operative mortality remains at 11%. Moreover, the authors had that the root management at index procedure was not in this study associated with proximal reoperation. Does root replacement technique impact the outcomes? With this study from Leipzig, where 374 type A dissection repair were evaluated, among the 208 56% patients who underwent root replacement, they compared the outcomes between Benthal, David, and Yakub procedure. Operative mortality was remarkably low in all groups, 1.2 to 3.15%, and follow-up didn't demonstrate any difference in aortic roots reintervention at 4 years. Also, the follow-up may be short. This paper suggests that aortic expertise can achieve outstanding results regardless of the replacement technique. Finally, our small experience. So from 2000 to 2070, we operate on 303 type A dissection. We did 188, 62% of supracoronary repairs, and 115, 38% root replacement. 7 patients required root reintervention on the spare roots. And in that 7 patients, 2 were reoperated on in an acute situation. Lie to fight another day. I think it's the philosophy of that surgery. And what we are doing in my department is that kind of algorithm. The root replacement is for dissection of 3 sinuses or 2 sinuses if the right sinus is in the dissection. Comorbidity and initial presentation is very important before to operate on. Marfan syndrome is in evidence, and patients less than 70 years old have an expectancy of life to treat correctly the roots. Entry tear in the roots is really it's a real problem because it's very difficult to know what is the frailty after surgery of the roots. So carefully evaluate the need for root replacement. Call a friend. Yes, a friend is, of course, a senior surgeon, but more than that, a surgeon who knows what is aortic surgery at 2 p.m. of the night. Close surgical and imaging follow-up, I think it's a very, very important thing for the cardiac surgeon who like aortic surgery. The follow-up is too often a lack of attention about our patient. So, take-home messages. Supracoronary repair in type A dissection is safe and reproducible, of course. In expert hands, root replacement, regardless of the technique, doesn't increase operative mortality in a nice aortic center. But only 10% of preserved aortic roots will require reintervention at 10 years, and it's questionable. Majority of the reoperations after type A aortic dissection repair are elective and can be carried out by senior aortic surgeon with low mortality. I really thank you.